Just a few points. Let's welcome you all to the meeting. It's good to see so many people and see more people coming in. You don't need me to tell you there's a huge amount going on across social care, health, and the wider scene at the moment. We're not going to talk very much about the general election, but we will mention it a couple of times because it's very important to the future of social care. We would urge you to vote. We're not going to tell you who to vote for. That's up to you, but do use your vote. Do consider how it will benefit you, your colleagues, social care and health in general. As I say, the meeting is being recorded. We have had a number of requests from you for Home Office partnership with regard to things like international recruits, etc. We are in contact with the Home Office. We are aware that the situation is a flexible one, and we aren't exactly getting a lot of response back from the Home Office at the moment. But we do have already posted on the website links to various parts of the Home Office. And if you've got specific questions, again, pass them on to Dudley or myself. We will try and guide you. And we can also point you at lawyers, people who can help you. But obviously they will charge you for that support. You will have noticed there has been or is about to be a change at the top of CQC. Ian Trenholm is leaving. We won't go into the politics of that. We've put out some requests for information, but had very little response, things like fees, etc., etc. So if you can help us with information, it's always confidential, but we do need to get that information so that we can supply data when we ask questions to DHSC, etc. And without that information, data is absolutely key. Dudley.
Good morning, Peter, and good morning, everyone. It seems that the wonderful merriments of technology of a computer always do that. So updates always come at those times when you never need it. But welcome, everyone, and very interesting to say hello to you. And didn't think I'd be saying it in the middle of a, I guess, in effect, a heat wave for us in UK. So make the most of it. And those who are lucky enough to be outside or have their windows open, enjoy it. And those without air conditioning, as we are not used to it, probably will have to be suffering quietly. Never easy, especially if you're working in a care home where they like to keep things warm. So, but apart from that, it seems to, and the election hasn't helped, been an extremely busy time for social care. Peter and I have been ever so busy across various fields, and so many things are happening. I guess there's two sides of the coin. At the top end, we do ask a lot of questions. We're at lots of meetings, but due to the election, lots of queries have almost been put on hold until after the election, which you can understand. But then the other flip side, and on the sort of frontline ground level, on the day-to-day, there's still lots of things going on and taking place from international recruitment, as we know, inspections, digitalization of the working place. I think there are quite a lot of concerns and issues. So we shouldn't stop there. It's not that the questions aren't being answered. I think we just have to understand the layout of the land. And Peter and I are doing our best where it doesn't hit you as providers and social care in the pocket or affect you. So we only know so many things. So please bear in mind when you do ask for our help that we are trying our best, but do whatever you do, as Peter said, put it in writing. We'll share it. We've got some great speakers that we have access to, as we have today. And we are part of larger groups which give up-to-date information or even information beforehand. So it's important. On notes of things like international recruits, we know that there's still a lot of international overseas recruits who still have been displaced. I'm in the middle of a project at the moment, and I'll send some details out, that's taking place not in London but based further afield, where we're looking at trying to put together a meet and greet with providers and displaced workers, where actually providers can actually go and meet them face to face, speak to them. They'll be vetted, and you'll be open to that. But it's in Blackburn, north of England. If that works, we'll potentially be doing something again in London as well. But I will keep you posted. Other than that, we know that things such as training should also, part of this group, and what we love about LCAS is that it's a meeting of minds of great people, from the WhatsApp groups along to just being here. Do reach out to other colleagues as well, where you can get assistance, which is really important. Peter meets with CQC as often as he can, so pose questions, but we also have a part of other larger groups as well. Other than that, I would say let's try and see if we can get as many things in and out of this as possible. Peter will update you on potentially meeting in July, if that is. If not, we definitely will be meeting in September, but we're not offline. We're continuously available if you need to get a hold of us. Other than that, Peter, I'd say let's get on with the show.
Okay, thanks very much, Dudley. Just one quick point. Are there any nurses with us today? Few nurses, jolly good. Apart from Mark Wareing talking about Brunel and placements later on in the meeting, there's also a new setup across London, which is has a wonderful title. It's the London Social Care Nursing Advisory Council, known as SNAC. Now, LCAS is a part of that, and the first meeting was extremely interesting, and it promises to do hopefully quite a lot for nurses in social care. So if you are a nurse in social care, please contact us. We will put out more information about SNAC as we get them. Good morning, Ali. Good to see Skills for Care here. And without further ado, we are very privileged to have Matthew with us this morning from Fulcrum. He's got a great set of slides. Whether we have a chance to get through all the slides, but what I would say to you is, having had the privilege of going through those slides, there's a huge amount of information there of great value to you with Skills for Care, with CQC inspections. So don't waste time in that sense. You will have the slides available to you on the website. You will have the recording, and you will have Matthew's details, so you can contact him and you can ask questions. But feel free to put them in the chat. And you know, there's 80 people with us today, and there's a huge amount of experience here. The problems that you experience, many folks would already have worked out a response to. May not have been the right one, but it'll have been a response. Matthew, good morning, welcome, and over to you. And I've got your slides, or you can put them up yourselves, whichever you prefer.
Yeah, please carry on and manage that, and I'll prompt you through.
Okay.
That's okay, Mr. Webb. First of all, just say thank you for inviting Fulcrum and myself to join you today. Just a bit of an explanation of who I am. I'm a senior consultant for Fulcrum Care Management Solutions, and we, as an organisation, have been set up to provide support to care providers across the UK, covering all the regulatory bodies in all their states of transition, along with a portfolio of fantastic consultants. And I can see some of them have joined us today as well, which is great to have them on board. So I am a registered mental health nurse. I trained in Kingston University and started my career in social care as a care assistant in a deaf supported living service, helping young adults access the community and live independently, and then progressed through the NHS, where I first qualified as a registered nurse, and I've worked through commissioning, area quality, and head of operations roles prior to having this position. It's interesting that Mr. Webb talked about the Social Care Nurse Advisory Council, because I was part of the initial setup of that, and would really support your involvement. And I believe the council chair for London would be Zoe Fry from the Outstanding Society, who is fantastically resourced. So please, if you have a chance to look at the Outstanding Society, do. And if you have any thoughts about things that can help influence system change then please take the opportunity to get involved. I think all of the Social Care Nurse Advisory Council information is on the Outstanding Society website. So the goal of talking with you today is to reflect on the regulatory inspection process with the CQC. So we know that this is a journey that started prior to the pandemic, and our engagement in it, the forums that we were invited to contribute to, occurred throughout the pandemic, which I think for a lot of us was particularly difficult because we were juggling other plates, spinning other plates, and maybe didn't have a chance to participate in that. But my perspective of the single assessment framework is that the CQC were trying to establish, or have tried to establish, a assessment framework that reflects modern care. And that is that modern care is about what people want. It's about person-focused, person-centered care, and making sure that that's provided in line with best practice and evidenced with people's involvement, whether that's taking proactive risk steps, or whether that's supporting people who may or may not be able to make their decisions themselves. The key point is that this is about the care that people need and deserve. So with that in mind, we know that one of the biggest variables about person-focused care is people, because we have our own perspectives, and our perspective on what might be the right care for us can differ person to person. And I think oral care is a really good example of that. So if you think about the process you took to brush your teeth this morning, it'll be different person to person. Some might not have brushed their teeth. Some might have used mouthwash and then toothbrush. Some might have just used mouthwash. Some might brush their teeth later in the day after their fourth cup of coffee. But it's about people's wants. And that's the challenge in this, isn't it? If we're creating a system that is about people's needs, people need to be consistent, but people are not consistent. So therein is the challenge. So as we talk through this, hopefully we'll be able to talk about some, explore some of the quality statements. I've picked some examples, and then also to think about some lessons that I've learned from the inspections that I undertake on behalf of Fulcrum using the single assessment framework. So unpick some of those, and then some quick lessons learned as well. Okay, so I think first of all, it's quite helpful to think about Fulcrum as an organisation. And as I say, we provide support to care providers across the UK. Another aspect of things that Fulcrum does is about looking into insights within the care sector. So if you access our website at the moment, you may come across a document which talks about affluence as its correlation to positive inspection outcomes, outstanding to inadequate, across England. And this report is quite interesting because it talks about how more affluent areas, there seems to be a higher correlation of homes services that are rated outstanding. That's community and residential based services. So this document aims to explore that and understand the correlation. And I think in a nutshell, it's really about those providers in the more affluent areas maybe having more resource to reinvest into the services. But what does that mean for those services who don't have that luxury and don't have that resource? And maybe we can answer some of these things today by exploring these quality statements and these experiences we've got. I'll pause there because I just want to reflect on Helen Bevan, who is a wonderful advocate for change management. And I think change management is a really important skill that we all need to consider if you haven't already. Because we're always changing systems within our services. We're always learning, which is a key theme for your inspection preparedness. Helen Bevan often posts on social media, and sometimes she references some good resources like the Harvard Business Review, which is a free online publication. And I think you can get up to 4 articles a month for free. Otherwise, you have to register to access more. And what was particularly interesting to me recently, Helen Bevan shared an article from the Harvard Business Review, which talked about steps to take if you want to change the culture within an organization. So focusing on change management. And the article was very clear that if you want to change a culture within an organization, a leadership culture, a performance culture, don't set out to change the culture, which seems counterintuitive. The article goes on to advise that actually what's really helpful is to look at the strands of the systems that are in place, and then review that system, make sure that's embedded, make sure it's functioning, and then move on to the next one. And by doing that, eventually you will have influenced the culture in the way that you want to, so that it's a team working together. So maybe try and remember that through the next few minutes as we carry on talking. And I'll give an example as I can. So if we are looking at medications management, we don't necessarily want to take the approach where we go in to the provider and just change everything and mess it all up, because that's what we see as the right thing. It's about understanding the systems and processes within an organization, and then following it all the way through from conception, policy, procedures, training to practical application, to make sure it's all functioning in the way that we want it to as our business. And I find this really important to think about, and I feel that it really ties in with some of these quality statements. So that's the end of that thought, but we'll link back to it. I'm assuming that because you're invested in the LCAS forum, that you're familiar with the ins and outs of the CQC inspection process. As Mr. Webb said, that these slides will be shared, and I will forward some links and resources as well that I maybe touch on as we're talking. But so therefore we know about the scoring system. Maybe we know about the inspection process. We know that about the changes that have been made. So it's still the same regulatory framework. It's still the same legislation. It's still the same best practice. And fundamentally, to bring it to a point, this is about how we present our information, how we demonstrate the great things that we are doing in our care services. Mr. Webb, would it be possible to skip to slide 16? So because you're familiar with these things, I mean, all this information is there for you to look at, and it covers the scoring and the other processes. But the quality statements for me, as here we are on slide 16, are the crux of this. And I think it's so important to understand some of all of these quality statements and look at those strands through your business to see how they're evidenceable and applied in practice. Okay. So we know that the quality statements have been formed through this involvement to create person-centered care, and that they're established to reflect it's a single assessment framework, provision of care and support through NHS, GP, community, residential-based settings, supported living. So everything has got to be quite flexible to those different settings. So if we skip to slide 18, please. There's this wonderful independent mental health nurse consultant called Lorna Warriner. And I'm in contact with her through social media, and we were reflecting on the key aspect of engaging with people. Remember, we're thinking about person-centered care and the quality statements through this. So Lorna works with people who maybe have a forensic history, are in prison services, and she reflected on that through this statement, which I've got displayed for you, that when you're working with someone and you're planning the care, it's not just about describing the needs and the risks, but it's about thinking about the causation. Why is someone presenting with this expression of emotion? What's the foundation for it? Where is that coming from? And Lorna goes on to explain here that if we know what the motivations for that person is, we can support them better in what they want to achieve, and therefore we have a greater chance of succeeding with them. listening. So I think listening is a really key theme, as you know, to apply through the quality statements, through your inspections, through your organisations, and I'll keep coming back to that as we move on. So would it be possible to move to slide 19? Great. So this information is taken from the CQC website. So there is an awful lot of information that's available on the CQC website. And the CQC state here that they are collecting evidence when they're undertaking their inspections in these 6 distinct categories. And the first 4 of those are about listening. So just as Lorna Warren was saying, listen to be able to get it right. This is about listening. The CQC are going to inspect you by listening to people's feedback and experience, whether you live there or work there, staff and leadership feedback, whether you're an external stakeholder. So if you're a care provider, your line GP, your district nurse, relatives that visit the service, charities that you're working in partnership with will be contacted, and the CQC will listen to their feedback. The other 2 areas there are about your operational processes, your leadership, your structure, your governance, and then the outcomes. So in the simplest form, if I've got a headache and I need paracetamol and it's administered in line with my PRN protocol, then what is the outcome? Was it to good effect? Or did it not work? Did we need to look into that? Is there something else happening in there? Is it an indicator of something else going in the bottom, in the body? What are the outcomes of the care that we provide? And how do we demonstrate that we've achieved that? So these are the 6 distinct categories, which are really interesting. Again, all this is available on the CQC website. So if it's possible to move on, Mr. Webb, to the next slide. So we can look at some of these quality statements here in greater detail, which is what I'm really privileged to be able to do with you. So this quality statement is from the well-led key question. And we know that well-led is a huge priority for the CQC. And it always has been, really. So if we have a focus inspection, if there's been a significant flag, maybe it's an unexpected death or a safeguarding or a complaint or whistleblowing, we might get inspected looking at safe and well-led as a focus inspection historically. And I think it's still the same. When we look at all of the quality statements, if we map them out, we see that there are 34 and they're broken down into different domains. And there's weight to this. So if we look at safe, there are 2 key quality statements and there are 8 sub-quality statements, if you like. There's the same amount for well-led. Safe and well-led have the same amount of quality statements. Whereas on the other end of the spectrum, if we look at caring, there is 1 key quality statement and 5 sub-quality statements, if you like. So this highlights really that the focus on safe and well-led is incredibly important still for the CQC. And if we take that a step further and we look at the regulations that are aligned to the quality statements, because as you explore this on the CQC website, you'll see that each quality statement, you can explore each one to see what it means on the CQC website, as they've explained it, the associated legislation and the aligned regulations. So a regulation that I find particularly important, and I love exploring and supporting providers to have good practice around, is around meeting nutritional needs. So that's regulation 14. And that's key, because if I have the wrong textured diet, for instance, or food prepared without consideration of potential allergens and so on, that I'm at risk. And we've seen this play out in the public. We see it in care homes. Maybe you've experienced a choking event yourself. Maybe you've experienced people who opt out of the prescribed modified diet from the speech and language therapist team. So I think this is a really important regulation, but it only appears 3 times throughout the quality statements. It's only lined in 3 times, and that comes under caring, responsive, and effective. Whereas if you look at other regulations like person-centered care or good governance or safe care and treatment, they appear throughout the regulations. So this, for me, reiterates that our leadership being well led, our governance, our person-centered care, that listening to people is really important. So coming back to this quality statement, well led, shared direction and culture, this quality statement clearly says we have a shared vision, strategy, and culture. This is based on transparency, equality, equity, human rights, diversity, inclusion, engagement, and understanding the challenges and the needs of the people in our communities in order to meet these. So just as Lorna Warrener was saying, listen, engage, understand the needs of people that we're providing that care and support to. And if we go onto the CQC website and explore what this quality statement means, we will see that it talks about the leaders of the provider, the care provider, have ensured that there's a shared vision, a strategy that all staff in all areas know and that they understand and that they support, and they're invested in the vision and the values and the strategic goals, and the leadership helps them to achieve them. That the website goes on to explain that those staff leaders know what the shared direction, the values and the vision are, and are supported to implement them, that they've been involved in developing that structure, and that it's about achieving high quality compassionate care. So I think this is really interesting for care providers, because it's, in one sense, it's about understanding yourself, what your visions and values are for your businesses. And then it's about showing how you communicate that, not just once a year or once a month, but every day, how you live that. And I'll explain why I think that's really important. Because if I wake up every morning as an individual and I start, my inner critic fires up, with my first cup of coffee, and start saying, you're useless, you're rubbish, I will believe that, and I will perpetuate that through my work, through my day. And it's frustrating. If I wake up and I set myself goals, I challenge myself, I push myself, I say, you can do this, you can achieve that. That is the rhetoric that I will hopefully live and believe and feed off. So if we as care providers are living and believing our visions and values every day and communicating those to our colleagues, to our teams, we are more likely to have a team that is invested in that, understands it, communicates it, and cascades it to our other colleagues. So if our vision and value is that we provide good care, we make sure that we're listening to people and we're involving people, then those visions and values will cascade down, if you see what I mean. So we need to live that. We need to communicate and make our visions and values clear and well evidenced. So we could evidence those, perhaps if we go to the next slide. Oh, sorry, the next slide is around some examples of how CQC have inspected this. So these examples come from a mixture of the CQC single assessment frameworks and prior to that. So this service, this is a good example of how the score rating comes in. You can see in the top corner, there's a score of 3, which we know a score of 3 equates to a good outcome. However, this service, when it was inspected, was rated requires improvement overall. And this is a good service. It's a very positive service that I'm aware of. So that means that under this key question, under well-led, if this was scored good, there's the weighting is that some of the other quality statements that were looked at have been rated requires improvement, and overall that's led to the overall rating. But you can see in this that this says the registered manager and staff displayed a committed attitude to people, and all of the staff told us that the home was a nice place to work and had a family feel to it. Staff said, I've worked here for a long time, and actually I know what I'm supposed to do. I know the visions and values of the organisation. The CQC are going to look at this, and it is important that we've got our visions and values communicated and invested in through our organisations. The next slide, Mr. Webb, gives another example of how this quality statement, this particular quality statement about shared direction and culture, is assessed. And this is either frustrating or great, because this the same question was assessed and this service was rated outstanding, which is fantastic. You can see the score of 4, which equates to outstanding at the top. This is how it's presented on the CQC website following the inspection. But it says we didn't look at it. We didn't look at this quality statement. We had no need to when we inspected. Because although there's 34 quality statements, we know that the CQC are looking at maybe 10, 11, 12, maybe more, maybe less, depending on their rationale for coming into the service. But they will have pre-planned that, of course. But in this instance, they didn't feel the need to look at that. And from previous inspections, they were really satisfied with how the service had met this standard, so that they're pulling that standard across to the current inspection rating. They're keeping it. They didn't see anything during the inspection that flagged for them, and they didn't see anything in their pre-information gathering that flagged for them as well. So depending on where you sit, this is either a good thing or a bad thing, but it does reflect how CQC inspections are taking place, which we can come on to in a little bit. We'll move on to the next slide, which I think explores another quality statement under well-led, which links to the previous one. So governance, management, and sustainability. So this clearly says, as you can read, we have clear responsibilities, roles, systems of accountability, and good governance. And we use these to manage and deliver good quality, sustainable care, treatment, support, and so on. We act on the best information about risk. So from the inspections that I've undertaken over the past few months since the framework came out, some observations that I've made. I visited a residential care home, and so non-nursing provision in a residential setting. And it was beautiful, and the staff were really caring. From a leadership perspective, the provider had 5 audits that they completed every year. We had an annual infection control, we had a monthly health and safety, and then we had a range of medication audits. So medication was really well looked at on a monthly basis, weekly basis. We counted the stock, that was great. But the rest of the service, we had quite a stark governance system. So if we take that example and we look at this, we have systems of accountability, good governance, and we use these to manage and deliver good quality. That service that I just described there were big gaps in how they gather information, how they assess, how they check, how they validate, and therefore how they use that information to improve their service. So I'm mindful that service may have really struggled with this quality statement if they were inspected against it, because there's little evidence to go on to demonstrate their governance and management systems. Another example would be a completely different provider, and I'm not telling you where these are because obviously I'm respecting the individual businesses, but they brought in a digital system to manage all their audits, which is great. And we're thinking about being innovative, we're thinking about cost saving with paper maybe, but the governance, the audits that were in place were confusing for the managers to use. So for example, they had, the online system had a daily walk around document, an ad hoc walk around document, and a monthly walk around document. And because of the way that we hadn't listened and involved people to set up the governance, we could see that the managers were confused about which document to use to evidence their walk arounds. And as a result, there were big gaps in the consistency of them, which again reflected poorly on the governance and management and sustainability. But also about making sure, coming back to these strands of work, that we're linking into the best practice. So thinking, what do the NICE guidelines currently say about supporting people to self-medicate, as an example? Or what are the local operating procedures from my NHS commissioners, my local authority, and what do they say about medications management in my setting? Versus, what are my visions and values for my organisation? So a good example of that is about how we manage controlled drug keys, for instance. So some NHS and local area authorities, ICBs, ICSs, if you like, have operating procedures which are quite specific about controlled drug keys being kept in certain places or with the key bunch or without, whereas other areas don't talk about that at all. So my sense is it's about understanding what you want to achieve, measuring yourself against the existing legislation and best practice, and pulling that in to make your vision, value, governance, and policy procedure clear and consistent, and then helping other people know it. So if we skip on to the next slide, Mr. Webb, we can see that there's some examples of how the CQC have inspected against this. So this home services we can see was rated inadequate. And it says here about being well led, that the managers and staff were clear about their roles, but there wasn't an effective management structure. The provider did not monitor the quality of care provided in order to drive improvements. So your audits and checks are key in helping you to understand what needs to happen within the home, what's performing, what's not performing, and then helping you to create a system to improve that, influence your action plan to improve that. So this home was inadequate for those things, and you can see some more details in there as well. The next slide shows an example of an outstanding service where it says governance was well embedded into the running of this service, and there was a robust framework of accountability to monitor performance and risk across all schemes. And I must highlight that this does not mean you need 100 different audits, but you just need a good framework that provides you assurance on the service that you're providing. The next slide shows another quality statement to look at. So this comes under the key question with responsive, and this is about person-centred care. So clearly this is a key focus for the Care Quality Commission and for us as care providers and people who are invested in other people. So we make sure people are at the centre of their care and treatment choices, and we decide in partnership with them how to respond to any relevant changes in their needs. So let's brush our teeth again. So in our care plans, how does it show that I am quite particular about oral care, want my mouthwash first, and then want my toothbrush second, and I want an electric or a manual toothbrush? How do we show in our care plan that I have been consulted? So sometimes care plans is a big contentious subject, I know sometimes, but sometimes I've visited services, and maybe this is going back a little bit, maybe 2013, where I visited a nursing home and they had one drawer with the local authority care plans written in the style that the local authority wanted. And they had another drawer with care plans written in the style that the NHS wanted. This was their perception. As a result, and I said to this team, well, actually, it's got to be about care plans written in the way that you want, your visions, your values, your culture as an organization, but also to reflect the person. So people can give you recommendations and preferences, but they're your care plans, and you're duplicating your time in creating two different systems. That aside, sometimes we write care plans as in the first person. So I like this, or we write it talking about the person. Matthew likes this. So what is the best way? I don't necessarily want to influence you, but what I would say is that if you're writing in the first person, it reads as though that person has written their own care plan. If you can show that they have written their own care plan, that's great. And that's a good demonstration of people being involved in making their own care plans. Otherwise, what can be helpful is using quotes. So we sat and spoke with Matthew about his oral care, and Matthew told us this. Therefore, this is going to be how we plan the care with Matthew. So we were demonstrating the involvement, we're demonstrating the inclusion and people's involvement in informing care plan relevant changes in partnership with them. Get people involved. Also, with your governance system, do you have a way of checking and reviewing people's involvement, people's needs? Because clearly wishes change over time, don't they? On a regular basis. So in its simplest form, some people think about having a resident of the day system, which means that we can talk with people. All departments of your service can talk with that person relatives can provide their views as well. So that's a really good system to have. So moving on to examples of how this has been applied or inspected through social care. The next slide, thank you, shows us inspection reports, one from pre-single assessment framework and others from during the single assessment framework. So this service here is taken from the CQC website, says that care plans were not person-centered. They did not reflect people's needs, and risk assessments actually failed to fully identify or mitigate risk. And this meant, as a result, the staff didn't know what the people wanted, and they couldn't provide that care and support in that way. And I don't think it's surprising to see that the CQC rated this service inadequate. The next example shows us a good service. So this service, and this was under the CQC single assessment framework, talks about people and, where appropriate, their relatives had been involved in creating and updating their care plans. One relative said, we're involved, and the resident is listened to. So isn't that great? So remember at the start, we talked about the CQC's objectives, that they will listen to people, they will gather feedback from people. And that's really important. So if you're living your visions, value and culture, if you're listening to people, then when that feedback comes back, this will be the kind of outcome. This could be a good outcome, and it could be a key factor. Listening is essential. Having a clear structure is essential. And the final example here on the next slide is another example of how the new inspection framework can take place. So we scored 3. We didn't look at person-centered care during this assessment, which is a ridiculous sentence because it's all about person-centered care when we're inspecting and we're looking at that. But, you know, to be formal, we took our rating for this quality statement from the previous assessment where we didn't have any concerns, and that's good. The next slide shows us an exploration of a quality statement under effective. And I think this is a really interesting quality statement because it talks about evidence-based care and treatment. Now, I'm sure everyone here is really experienced in care and provision, and that's why you're here, that's why you're involved in this brilliant forum. But how do we demonstrate that we're delivering evidence-based care and treatment? When we're, and I'm sticking on the subject of oral care, but when we're looking at oral care, we know that we can refer to guidelines and best practice, such as NICE guidelines, the National Institute for Care and Health Excellence. And it's actually starkly clear within the recommendation section. I think it's NG, NICE guideline 28, I think, if you want to search that up. But within the recommendation section, it's very clear that says that people should have their teeth brushed twice a day using a fluoride toothpaste. So if we write that in the care plan, Matthew should have his teeth brushed twice a day using a fluoride toothpaste. Is that evidencing our best evidence-based best practice care? Are we evidencing it by writing that in the care plan? Or could we then take another step by saying this care plan is written in line with, and copy the link in, and the best guideline says to do these steps? There are so many nice guidelines that can really help us in this way. End of life, medications management, pressure prevention, and so on, and not just nice guidelines. And actually, when you go onto the CQC website and explore the quality statements that are listed there, scroll to the bottom, and you've got a list of associated legislation and best practice documents. Again, some of them are not relevant because some are designed to encompass the NHS services, GPs, and so on, as well as social care, because it's a single assessment framework. But I think it's really important to make sure that we're measuring ourselves against this. Or if you're a nurse and you're familiar with your Royal Marsden Clinical Skills Guideline, page 380 or whatever might talk about, I don't think I've got the page number right there, but it might talk about the steps that you take to catheterize someone or help someone with their blood sugars. And the steps are written out quite clearly for you. And so that's maybe a good document to reference in terms of best practice. Okay, there is another example on the following slide which talks about how the CQC have inspected this. So you can see this was scored 2, which requires improvement in the scoring framework. And it talks about how the registered manager had struggled with this because staff had a lack of understanding of the guidance around right care, right support, right culture. So this was a younger adult service, and right care, right support culture is some best practice guidance published by the CQC on this matter. So people did not always receive the support they needed because we hadn't implemented this best practice guidance. There are other ways of demonstrating that as well. On to the next slide, there's a list of some other focuses, so things that I have observed and want to share with you about CQC inspections and making sure you're ready for it in line with the single assessment framework. So practicing. Now, if we take an example of maybe your driving license, you practice, you spend an awful lot of money with your driving lessons, an hour a day and so on, and you practice to make sure you pass. Actually, I think the better drivers pass on the second time. I'm definitely one of those, but you practice, you invest time into it. If you're a registered nurse, you practice your OSCEs before you qualify. If you're employing people, you help people to practice their moving and handling skills or dignity and so on through the training courses you provide for them. Your good governance, your visions and values are reflected in that. So I think it's equally important to practice hosting an inspection, which is kind of where I've got all these observations from, because I do undertake mock CQC inspections. What I think this practicing an inspection gives to you is understanding when you're inviting people into your home, when a CQC inspector turns up unannounced, you know how to respond. Your staff know how to respond. You're practicing the types of questions that your staff will be asked by the inspectors. And you're practicing how to facilitate the inspection. So that the inspector comes to the door, they show their badge, the staff don't panic. They know, oh, welcome. This is a response you want that reflects your visions and values. So practice it. Also, by practicing an inspection, it means that you're getting a fresh perspective on your systems and processes, and maybe some recommendations and suggestions into how to tweak or enhance, or just that assurance that actually we're doing okay. Practicing inspection, I think, is a really important key. It is, the single assessment framework has been around for since we have lots of information over the past couple of years, but just making sure that you're practicing it, making sure you're demonstrating how you're evidencing these quality statements, I think is really important. The next point there about sharing digital records, I think, is key also, because we know our inspection doesn't just happen on the day and then it's over. And we know now that the CQC are gathering that information, they're listening to your external stakeholders, they're liaising with your GP or district nurse and so on through information gathering processes. So it starts months before they turn up at your door. And then you've got the inspection day, which, as we saw those points earlier, is about observing, is about listening, is about gathering feedback. And then after the inspection, you'll likely have a request for some evidence, some documentation to be sent over for the inspector to analyse. Now, what they'll be doing with that is they will be looking at triangulating information and observations with the experiences they had on the day of inspection. So how you prepare, review and share your digital records is really important. Because if we just email documents over, here you go, here you go, here you go, without an explanation of what that information is, without managing the data protection issues that are integral to that, then we're not giving ourselves a good chance to have a best possible outcome from our inspection. So if we're gathering information, review it, check it, make sure it reflects what it should reflect. And then when you're presenting it, maybe write a bit of a contents page. So, dear CQC inspector, in folder 1, you will find this document, that document, this document, which supports, in my belief, this quality statement. So just think about how you're presenting that information. I do think it's incredibly important to familiarise yourself with the quality statements if you haven't already. And remember, it's about little and often. It's about the strands, isn't it? It's about the workflow. So if we look at them all once, that's 34 quality statements, and it's maybe too much information, but looking at them through different themes, maybe once a week you pick a different quality statement and you talk with your team about how you think you're evidencing that, and you're putting that quality statement into practice within your service. And again, it's preparation for your inspection. I think the next point there about legislation is really important. And it's a bit like the care plan example I gave earlier with the 2 drawers. Often we come across services who have been told by external health professionals, and I'm not singling anyone out at all, but to do something. And a good example of that I've listed there is about application of the mental capacity assessment. So often I've visited services, and I'm sure you're all familiar with this as well, where providers have been told to put in a mental capacity assessment for each individual domain of care. So oral care, the breathing care plan, nutrition, hydration, whatever care plan it is, an NMCA for that, which we know when we look at the code of practice is not the correct use of that legislation. Mental Capacity Act is about helping people to make decisions about their care and support, and shouldn't be mandated throughout everything. It's where you need to help people to make decisions. So if you know your legislation, not just Mental Capacity Act, but other local and broader best practice and legislation, then you're in a better place to professionally challenge where and demonstrate your understanding of those systems and processes. And another example I picked up from my recent travels up in the Northwest, I visited a service where they had been rated inadequate under SAFE. And on the inspection report published on the CQC website, it talked about the recording of thickener on the MAR chart and how it hadn't been recorded for each administration of thickener in a drink. So actually, when we think about the medication administration records, there's not sufficient space to record every drink that I have. I might have 8, 9, 10 drinks a day, and to record that each time. A bit of research identified that the local NHS and a local authority service co-published a document with the speech and language therapist input that talked about, actually, we don't expect you to record that on the MAR chart, but definitely in the care records. So if that provider rated inadequate in part for this, was aware of that, then maybe they could have challenged that, and maybe that could have had a different outcome on their inspection. So know your legislation and best practice at those different levels. Moving on to employee wellbeing, because environmental impact is significant, but I think employee wellbeing is more so. So remember, the CQC are asking for feedback from your stakeholders, your employees, and people living and accessing your services. Employee wellbeing is really important, and it can come in many forms, whether that's helping people with period poverty by providing products in appropriate spaces, or signposting people to wellbeing, counselling, coaching if they need it to, or linking up with the brilliant Care Workers charity who support care workers through grants and access to other services. But it's also, especially with this climate, with these changes, with people accessing work in the UK through sponsorship, it's about making sure your service is a good service and it cares about people. So if we go back a few decades, what was really important was information. Information was power, and that informed our work choices. Now, post-pandemic, quality of life is a key thing for employees. Excuse me. So we want employees want to be able to have that maybe flexibility, to have that time with family, as well as to enjoy their work. So employee wellbeing is a really key aspect for you to think about, link with the caring aspect of the quality statements, and understand how you're supporting people. And I've seen some wonderful examples in London of some community providers, for instance, who are supporting people, providing prayer spaces, lunch break spaces, helping people to travel around the borough that they're working in a really safe and considerate way. And that provider was actually considering the environmental impact as well. because we know in London it's harder maybe if you've got your own vehicle, and we have to use public transport as a better way. They had considered a scheme helping their employees with bicycles and pooled bicycles, and also support to access public transport. So environmental impact, I think, is a really key thing. And I recently had time to join in with a webinar that was co-produced by an NHS in the West Midlands, NHS provider in the West Midlands, and a charity called Grace Cares. And they'd reflected on what really helps with this quality statement, because there is clearly a quality statement about your environmental impact now. It sits under well-led. It's not currently assessed, but it will be assessed. And the feedback was, just think about that work stream, think about who you engage with and what is their environmental and policy, and how do you make sure that you're working with people who are reflecting your visions and values. So if we maybe remove these slides now and just come back to the key points in conclusion. So it's about listening and understanding the processes that you have in your business and making sure they demonstrate what we're asking in these quality statements, making sure they reflect people's involvement and they measure to best practice, making sure our governance systems demonstrate how we've listened and involved people, but also how we're checking and validating services. But practicing, I think, is another key point there. But thank you.
Fantastic. Thank you very much, Matthew. There's a huge amount of information there. You attendees will not have seen the bulk of the slides, but we have. And I suggest that when they go on the website, you go through them. There's a great deal of learning there. If you want to make contact, you can easily make contact with Matthew, or you can do it through Dudley or myself. And I would guess that there should be some questions for Matthew, even if they're only from Dudley.
Very quickly, thanks for that, Matthew. I usually talk a lot around the mindset of us in the sector. I think there is so much knowledge that we sometimes don't utilize, but also as well, the information that a lot of providers have at hand because they're running a business, because sometimes they're scared because CQC are coming, they sometimes forget what they're good at. And it's also a reminder of all the good things that you do. I sometimes say, go and look at why you came into the business, why you came here, all the things you can do. Because a lot of the time you speak to providers and they say, oh, I knew that, I just forgot, or I didn't look at it. So also think of yourselves as being the best that you can be, and that is possible. And if not, learning from great people around you, being in rooms where you see what good looks like is hugely important, what outstandings look like, what you can aim at. I think most things are achievable, and if you can't get there, by all means, try and use a consultant professional or upskill yourself by going on courses. There's so much there that can bring you up to level. Don't think that these people got there overnight, but they all were probably at a stage that you were at some point. So it is possible. But yeah, I'll open the floor. We haven't got as much time, but anything that we can't, or any questions that we can't meet today, please send us a message and we'll send it to Matthew. But also as well, we can't forget Fulcrum as well, because Fulcrum as a big organization are doing so much. Mock inspections are really also great and important to help you along the way as well. So please, if anyone wants to raise a question in the chat box, they can, or raise a hand that you may want to ask, please do.
Mr. Sawyerr, whilst we're waiting for that, just to reflect on what you said, and I completely agree with that. It is important to learn, but also it's about remembering that you're one person, and it's develop a team. So if you're learning, pass it on, influence that change. And something else that was discussed yesterday, I was visiting another provider yesterday, was about demonstrating link or lead roles in your service. So whether that's infection control, meds management, dignity, allyship, equality leads, and how we need to make sure that those people who put their hands up to become a lead are supported in a more in-depth way than colleagues to fulfill that role. And are they given time to do that? And it seems counterintuitive from a business perspective because we need to make, time is money and etc. But it really is worthwhile because having a good outcome, contented workforce, clear visions and values influences the business, doesn't it?
Yeah, I mean, before we go to Femi, that's great. I always say, if you're valued potentially, or your employees are valued, they're likely to add value as well to the service. So also bear that in mind as well. It's hugely important. Femi, I think you've got your hand up. So please, great if you could share your question.
You're on mute, Femi.
I'm not sure if maybe Femi's hand was up on purpose. Maybe something's happened. But there's a question quickly in the chat box, just for you to answer, Matthew. Is Fulcrum working in the whole of the UK? And is there also a network for outstanding providers to share good practice and knowledge? Thanks.
Great question, Georgia. And yes, to be concise, Fulcrum covers Scotland, England and Wales. I'm not sure if we've a background in Northern Ireland. I'm not sure about that, but definitely Scotland, England and Wales. And we have a portfolio of consultants who have a wide range of experience. The Fulcrum provides support for mock inspections, but also turnaround services, interim managers and so on. And what I can do is send a list of links to be shared through Dudley and Peter later, because there are some fantastic networks for outstanding providers as well. First of all, the Outstanding Society, so they have some great podcasts, and Zoe Fry is brilliant. Secondly, Skills for Care, and some of their podcasts, I think there's one of my favorite, which is the first podcast at the start of season 2, where there was a professional talking about compassion, which is wonderful to hear. But those are great resources as well. But there are a lot of resources out there to share and help.
Hello, sorry, Dudley. I'm able to unmute myself now. This is Femi. Can I go ahead to ask the question now?
Oh, fire away.
Okay, then. Thank you. Good morning. My name is Femi. I work with Spring Care, we're a care agency. My question is really centered around the new inspection system. And I just wanted to know that I did hear that sometimes they don't have to physically come to you any longer. They can do it remotely. And we have the electronic monitoring system and all that stuff. So I just wanted to know if in preparing and getting ready for this inspection, that you can sort of just collate all these documents and all that, and sort of then have all this evidence that you have, because one of the problems we had was about feedback, and we felt like maybe the feedback could be done electronically via Google, I think Google feedback system. But what I actually just want is that, what advice would you give in terms of the sort of documentations to put together? And also, is it okay to actually give them access to your electronic monitoring system for them to look at? Or, you just photocopy them and then have them have those copies rather than them, because I don't know if they may just go to other places where you don't really want them to go to if they have access to your electronic monitoring system.
Well, this time in 2 weeks.
That's a really good question, Femi, and I think there's a lot to that. So first of all, your digital care provider, you can work with them to set up an inspector login, and I have come across systems where that means that some areas of your care records have been restricted. So your housekeeping, things that are not swept under the rug. That's a very bad phrase to use, but you want to show your presentation and maybe not the working out. So that's a possibility. Also, more importantly, that yes, be prepared. That's a key theme that I've been reiterating throughout. And your governance system can be your evidence that you're gathering, can't it? So if you have a complaint, a compliment, your feedback system, and maybe a complaint, maybe it is through Google, maybe it's through carehome.co.uk, maybe, or homecare.co.uk, or another system, that you have a record of that, digital or paper, and then your response to it, and then if needed, a lessons learned, and those documents are together. And if it's digital, you could have a format ready as part of your governance system as your best practice, your evidence to submit. So I think there is an element of everything that you suggested there, Femi. Yes, make sure you're prepared and think about how you're going to present that information. If it's paper and your photocopy, it's going to be a lot harder to send and prepare. If it's digital and ready, it might be easier.
Thanks very much, Matthew, and thanks very much, Femi, for the question. If there's any more, we'll take them in writing because we really need to move on to Dr. Wareing from Brunel University, which is something that Dudley and myself, find very interesting, and hopefully you too will find it interesting, and something that it's very useful, we believe, for the future of social care. So, Dr. Wareing, sir, please, off you go.
Thank you very much, Peter. Can I just check how much time I've got?
You've got about 20 minutes, 15, 20 minutes.
Oh, yes, I should be able to do it in that amount of time. So lovely. Thank you very much indeed. And I just want to congratulate Matthew actually on that presentation, because I thought it was comprehensive, it was clear, it was concise. And I think I'm going to be booking Matthew to come and speak to our students actually, because I think they would be inspired by the key messages within his presentation, as I'm sure you all are. So greetings from Brunel University London. It's lovely to meet you all, lovely to see you all. My name is Mark Wareing, and I'm Director of Practice Education in the Department of Health Sciences at Brunel. If you're wondering a little bit about what Brunel University is all about, I'll tell you. We are based in Uxbridge in West London. All of our services, all of our teaching is provided on one campus in a very leafy part of Uxbridge, right next to the cemetery. We have an interesting structure in the university because we have 3 colleges. So we don't have faculties, we actually have colleges. My college is the College of Health, Life Sciences and Medicine. And within that college, we've got my department, which is Health Sciences. If you've ever watched an episode of Inspector Morse, or even worse, if you've seen some of the films from the 1970s, like that horrible film by, oh gosh, I've forgotten, it's gone straight on my head. Anyway, any films shot in the 70s that require a concrete background, a Clockwork Orange, that's it, it's come back to me now. You'll recognize some of the buildings from Brunel University because they're quite brutal. They're sort of angular and, as I say, built in that sort of very brutalist concrete sort of architecture of the 60s and 70s. So we're what's known as a plate glass university. In other words, we were established in 1966. And I'm sure you know that universities are facing some difficult times at the moment. We reckon that about 25% of the universities in England are going to be in the red by the end of the year. We are not amongst that 25%. So financially, we're holding our own. And the reason why we're doing well is because we recruit a lot of international students. And so if you visit Brunel, one of the things that will strike you immediately is that the academic team are very diverse. So we recruit a lot of staff from obviously right across Europe, North America, Africa, and Australasia. And our student body is also very diverse as well. So we recruit a lot of students from the States and from Hong Kong. And the reason why is because if you come to Brunel and you train as an occupational therapist or a physiotherapist, your qualification is recognized in those countries, and we're one of the very few universities in the country that provides that for our students. So what do we do at Brunel in terms of health and social care? Well, we have an established social work degree course, a master's level degree course. We have occupational therapy, so we have the London School of Occupational Therapy. We have physiotherapy, we do global public health, and we also do nursing. And like Matthew, I'm a nurse by background, so I trained at the end of the 1980s in Birmingham, which is why I've got this terrible accent. Not quite as funny as Lenny Henry or some of the other great Birmingham comics like Jasper Carrot. But yeah, so I'm originally from the West Midlands. and I've worked in higher education for 20 years now, in a range of roles in health and social care, and obviously in practice education recently. Why have I'm asked to attend this meeting? Well, Peter very kindly invited me, but we are really keen at Brunel University to promote social care as a first career destination. So we are committed to our occupational therapists, our nurses, and perhaps our physiotherapists, and certainly our social workers, to consider a career in social care in London as their first career destination. Now, I can only do that, and we can only do that if you help me. And so what we're looking for really is for opportunities for students to taste social care. So it could simply be that you come to our campus and you tell us about your services. It could simply be that you come and tell your story about social care. And I would make you very welcome at Brunel, and our students would love to meet you, because when they're meeting people in the flesh who do the job, that's far more powerful than somebody such as myself standing at the front and harping on about social care. So if you want to come and speak to students and meet with students and come to our recruitment fairs, we'd be delighted for you to come and meet with students, and we would give you a tour of the campus, and we can show you our simulation facilities. The other thing I think that we can help you with is actually employment, because if you do a 3-year or 2-year degree, you need to work, not surprisingly. And so our students are looking for employment, and appropriate and relevant employment. So again, potentially there's opportunities for you to talk to students about part-time employment. But I would argue that one of the strongest opportunities is for you to think about students having some practice education experience. And we know that it may not be possible for you to offer a full-time 5-day kind of placement for students. So again, we can work with you and say, well, okay, if you can only provide, say, 2 or 3 days of a practice education experience, a placement in your team, in your service, in your care home, etc., then we can work with you around those 2 or 3 days. And then we can think about, well, what do we do with the other 2 or 3 days? Because students need to complete the rest of the week. And so we work with different providers to provide virtual, digital, blended learning, which would be relevant to that in your face experience of social care, as it were. Now, you might think, well, okay, that's fine, placements, there's a surprise. Universities are always asking for placements. What's in it for me? Well, we have a student tariff. So when students complete a placement, you can apply for payment that you can then claim from NHS England, and we can obviously support you with regards to the payments for placements. We can also support you with things like training in terms of nurses and physios and occupational therapists becoming supervisors, assessors, and practice educators. And obviously we can put you in touch with some of the many course opportunities that there are at Brunel in leadership, in management, healthcare management, in social work, and our advanced clinical practice program. But also, we'd like you to come to us and say, actually, this is what we need. These are our service development needs. And the reason why I say that is because we're going to be setting up a new hub for workforce development, because we know that there's massive workforce development needs within social care. And we're going to be setting up a new hub where we can work with organisations, practice partners, social care providers, and the NHS to identify what their workforce development needs are. So we've just been awarded outstanding from Ofsted for our apprenticeship provision, which is great. So we've got expertise, we've got a dedicated apprenticeship hub within the university. But if you've got other ideas about continuing professional development and courses that you think that you need some support with, then please contact us, because again, we can support you in that regard as well. Because obviously we're keen to support North West London. We're committed to the local social care and health economy and to developing the workforce for the future. And as I say, we're really keen that students see social care as a first career destination. When I did my nurse training at the end of the 1980s, you just went into a hospital. That's where you went. And after 3 or 4 years, you decided what speciality to go into. And eventually you kind of work out who you are and what you want to do. And we don't want that for our students, because our students come with experience of working in health and social care. Many of our students are mature, so they may have worked in health and social care before starting their physio or occupational therapy degree, and they may not necessarily want to work in a hospital. And we absolutely recognise that. And we want them to move into careers and opportunities where they feel fulfilled and where they can make a real difference to the social value of contemporary social care services within London, and obviously promote independent living and get excited about independent living and all that that entails. So I think I've probably said enough. I think you've probably heard my terrible West Midlands accent long enough. So if you've got any questions for me, or if you want me to shut up, then that time has come. Thank you very much indeed.
Thank you very much for that. This is very interesting. I mean, it's quite intriguing how education seems to be now meeting with social care, understanding that social care exists, because you play a huge part, not just in community, society, but also as well with the courses that we're doing. And if the universities can help support the development of, why I say, managers who have so many things and highly intelligent, and they don't probably get the plaudits that they deserve. It's great that they can also upskill themselves by going to such a prestigious place like Brunel University as well. So I hope, and Peter will let you know, that we will get a raft of people hopefully taking one side of upskilling themselves, but also as well utilizing your offer of these wonderful array of students that are here. So it would be very intriguing. Very quickly before you go forward, how will the process, what will happen then? So for example, if we have providers who want to take on some of your students, what's the next steps?
Yeah, so simply drop me an email, or you can ring me. I'll put my details in the chat very shortly. And then what I'll do is I'll arrange a meeting with you, preferably face to face. I'd like to come and visit you and see you, and we can identify precisely what your needs are. And then if you're interested in practice education, interested in providing a placement, we would sit down, we would explore how that would work for you, what kind of length of time you're looking at, whether that would be rotational, hub and spoke, whether that would be 2 or 3, 4 weeks, 6 weeks, 8 weeks, etc. Obviously what the needs are of your team to support students. And then obviously we would then move towards doing an audit so that we can get you absolutely shining and ready for your first students. And when your first students arrive, we won't leave you, because every student will have a linked lecturer. Every placement has a linked lecturer. So that will either be a lecturer or senior lecturer supporting the students in practice, answering questions around assessment and all of the needs that are required when the student goes out to practice education. So that's really pretty much how we work. As I say, we like to be flexible, and we like to try and find a solution that doesn't cause disruption to your service and adds value to the service that you give, and provides a transformational learning experience, not just for the student, but for the rest of your team as well.
Yeah, sounds great. What we'll probably do is either arrange, because rather than you having multiple interviews every 5 minutes, which could be, we might arrange to have a time and date where you can maybe do an hour specifically with providers, where there may be sort of like Q&As, and maybe you may be able to have some students available as well, which can just give us their thoughts, because it's always, we don't want it to be one-sided where the providers say one thing, but also we also respect that, you know, the students and obviously some of their needs and areas and spaces and requirements as well. So maybe we can do that, and even, you never know, maybe if we find a place, maybe an in-person meet and greet, and they get to meet the providers and they meet the students. That may be something of potential. So yeah, it seems.
I say, if you're looking for a destination or a location, we can make rooms available at Brunel as well.
There's a couple of questions have popped up in the chat. Did you say that you have a nursing educator course?
So what we normally do is we signpost nurses to practice supervisor and practice assessor training resources. So it could be that that's done online. It could be that they connect with their nearest NHS trust. If it's for the support of physiotherapy or occupational therapy students, then we provide our own practice educator course.
Hopefully that was from Femi. Hopefully, no, that somebody's asking for your details, but that was from Harriet. Did that answer the question, Harriet?
Okay, I've got another cheeky question. Well, I'm going to jump in before someone else asks a question. Are there any short courses? Because I know lots of managers or staff are fearful of having to dedicate maybe 2-3 years on a full degree course. Are there any short courses that they can take on that they can do that can help them?
Yes, we do. Most of our modules are delivered on what's called a standalone basis. So you can look at a suite of modules and you can dip your toe into the water and do that module and then see how you get on and then return with a view to topping up to a larger award like a postgrad diploma or master's degree. So yes, and obviously CPD, our continuous professional development opportunities, you'll find on our website.
I think there's a question here from Georgia, which is, do we actually need to have nurses and OT on our teams to arrange an apprenticeship placed with us?
It depends, because if you don't have a full-time physiotherapist or occupational therapist or nurse, what we can sometimes do is we can do remote support for students through something called arm's length supervision or indirect supervision. So, for example, if you do have somebody within your service who can supervise that student, then we can still set up a placement as long as they've got something at arm's length to support the student. So again, there's lots of flexibility, lots of ways of doing this, even if the student can't work with a nurse, a physio or occupational therapist every single day.
And I think on the OT, we're seeing more and more noise requests, information around OTs in social care. It's becoming a growth area. And we've actually seen a number of OTs, we talked to a number of OTs who started out in social care and then became OTs. They've done very well. And they've obviously gone to a university or a training body to develop that. And I know apprenticeships were mentioned. Before we move on to the next question, many people in social care have a poor opinion of apprenticeships and how they operate. There are many ways of apprenticeships in the same way that there are many versions of painkillers, and they can work extremely well if they're for the right people and they're properly managed and led. And the ones that are very good indeed. It's a very good grounding and a very good training. Further question, this is again from Femi, will this arrangement also be for students to have practical experience in the world of care?
Yes. So, I mean, for example, if you think that there's a particular experience that would be useful that you can't immediately provide, then what we can do is we can sit down and say, well, okay, explain to us what you need. And then what we can do is we can build a placement which spokes into that particular experience of care. So there's lots of ways we can do placements using kind of like a hub and a spoke type approach where obviously the learning outcomes of the student is met, but also fits with the connections of the services. Because I appreciate, you know, not all services are standalone. There's services that are split between different agencies. And actually, we are really excited in those alternative models.
Can I also add in there as well very quickly? I think it's hugely important as well, because there is always sometimes the notion where student comes into a service and it's like jumping from out of the fire to the frying pan to the fire, and understanding the way a working practice works is completely different from being a student. As we know, the experience is really important. Also as well, from knowing in the sector, even now the cross between residential and nursing is very blurred. So residential is probably could qualify almost as much as nursing. So having that insight is also very good for the student as well. Be in a situation, especially things around dementia now, as you know, is a huge area and growing. So definitely something to really tailor or speak to about in yourselves.
I mean, I think in simple terms, students are happy to put their uniform on. They're happy to travel somewhere that's not too far and easy to get to, and they're happy to participate in care, and that's what they want to do. But you're absolutely right, Dudley. I think expectation management is really important, and pre-placement preparation can make a difference between a student turning up and saying, well, you know, I've worked in a care home before and not seen the true value of building therapeutic relationships, learning about therapeutic communication, activity, and all of the really important skills that are the hallmark of excellent social care, as Matthew obviously alluded to earlier on.
I think one of the reasons that we are keen on linking with situations like this is that we need to rebuild the value of nurses in social care. The areas around complex residential needs such as dementia and end of life can be well handled in a residential sitting. But again, it's good training that's required, and some of that is coming through university-led courses. There was the mention of leadership and management courses, which are above the levels of level 5 that is funded through social care. So it's a funded area with a relationship to social care and health. As the ICBs, ICSs move through, there is greater integration. This is coming bit by bit, like it or lump it. And we are seeing some improved areas of commissioning, joint commissioning, again, which impact on the quality of care output. And single assessment framework, CQC, again, it's back to quality, and it's about the people that are being cared for and supported. And on the, just quickly mentioning training, John Buttle was going to come today and talk about the funding, where workforce development funding from Skills for Care has been replaced by that from the DH. There is really no update because the paperwork wasn't signed off before the election and so the situation is now, unfortunately, that nothing happens until new people are in charge. And so then they will send it off. There will be a further delay. The good news is we know there is a greater amount of funding and it is able to be more widely used. However, that is the devil is in the detail. So you're going to have to wait, unfortunately. We're all going to have to wait for that. But I would just like to thank Matthew and Mark both for coming today. Fantastic presentations. There's lots of information. And if you think that there's over 100 people in the room today with an average say experience of 10 years of each of us in social care, that's well over 1,000 years experience. There's a huge amount of experience and knowledge amongst your fellows. Do talk to people. And if we can get a group of people to work with, say, a university group, and sorry for my cat invading the screen, it actually builds a greater atmosphere of quality across the care sector. And working with health, there aren't two separate things. I know health and social care are called two separate areas, but in effect, they are not. They're going to have to work together and CQC and the NHS are going to have to get used to stopping calling everybody patients and getting the terms right. But we need to get some shared terms, and we do need to work more closely together. So again, thank you both. Thank you, Dudley. Any final points from you?
Yeah, thank you, everyone. We haven't got anything set for July. Obviously, the aftermath of the election is one thing. there's a lot of moving parts that are taking place. So potentially do look out for emails, WhatsApp, and information. We're speaking to various people such as Fulcrum, obviously such as Mark, and we're trying to set up as many things as possible. We also know as well things like international recruitment and staff being displaced as well, trying to find a home for them. I'm also getting lots of messages as well from managers or people moving services, and people looking for work or looking to change employment. So also as well, do reach out and put messages on the WhatsApp group, and we will let people also know as well. We don't want people to leave the sector of their good skills and knowledge, and rather stay within the sector where possible. So if anyone's looking for, or maybe a good professional, we have good recommendations here. It's really important. So thanks again, everyone. Do keep sharing any other information or areas you'd like us to touch upon. We try our best to fulfill as many things as possible. And we know that hopefully August is warm and you're able to obviously deal what you have to deal with, because we know September to the end of the year is going to be extremely busy. So thank you, everyone, for joining in, and have a great rest of the month.
Okay. Thank you very much, everybody. And we will be in touch. We'll circulate when the information is on the website, and we will put everything there. And we may actually do something on staff retention. That is an area that has been touched upon. We've been asked to do something, so we may well put something together. But enjoy the rest of the day, enjoy the sunshine, and if there's anything you want, please let Dudley or myself know. Thanks again. Bye now.
Thank you. Right.
Thank you, Peter. Thank you.